Yeah, good morning, everyone. Welcome to Seattle. If you're not natives of Seattle, and it's a pleasure to have you all here. It's wonderful to see a full room. This is an auspicious year for me. This is 2018, and I first arrived in Seattle in 1968. So if you do the math, I've been here for 50 years. So this is my 50th anniversary, and I'm going to take the prerogative of the elderly person on the speaker's podium to talk about history. My two favorite topics are science and history. So I want to combine those and talk about history of Charcot-Marie-Tooth and show you the history of this disease as it developed here in Seattle at the University of Washington, because we've been involved with CMT clinically and with research for almost the entire time that I've been here. And when I first arrived, there was a family that had been seen at Children's Hospital here in Seattle, and I just made a figure of the family pedigree that the pediatrician drew in the patient's chart in 1962. And so you can see there was a grandmother and her son, and he had, with his wife, he had 4 children, and all 4 of the children had developed CMT. And so they were coming to the clinic, and it's interesting to note that they were wondering what exactly this was. Was it polio? Was it muscular dystrophy? Was it cerebral palsy? They actually weren't sure about the diagnosis. It shows you how far we've come in 56 years. So I did a neurology residency, and then I specialized in medical genetics, and so I've combined hereditary diseases of the nervous system. That's been my specialty for the last 40-some years. And we started working on Charcot-Marie-Tooth in 1978. This is the timeline I'm going to show to you in a bit of detail, going from 78, the next 40 years, up to today, and give you an idea how we worked in this field and tried to understand what was going on. You know, a lot of it is like the story of the blind men and the elephant, and they think the elephant is thin because they're feeling the tail. They think the elephant has very thin, big skin because they're investigating the ears, and then they realize that it's kind of a fat animal because they're looking at the feet, but they're trying to put it all together, and they have to talk to each other and keep feeling the elephant until they begin to put it together and understand what they're dealing with. And that's kind of like what Charcot-Marie-Tooth has been over the years. So in 78, I started working with this guy who some of you who've been around a long time may know. This is Dr. George Kraft, who was a physiatrist in physical medicine rehabilitation at the University of Washington. And we had these families come to our clinic, and there would be Charcot-Marie-Tooth diagnosis in the family, and someone who was a child of the affected parent would be around 30 years old and wanting to have children of their own, and they would ask us, have I inherited this disease or not? If I've made it to age 30 and I'm not showing any sign of the disease, am I safe? Or could I still go on and develop the disease? And that was a great question. There were many genetic diseases where there were graphs of age versus onset of symptoms, and you could tell a person at any age what their likelihood of having escaped or not by examining them and knowing their age. There were no such graphs for Charcot-Marie-Tooth, so we didn't know what to tell those individuals. So Dr. Kraft and I collected about 20 families with Charcot-Marie-Tooth. We examined every child in the family. We did children, adolescents, adults, and tried to figure out what could we tell individuals as they aged, whether they were escapees or not, based on their nerve conduction studies and their examinations. And it was quite a naive study, actually. We had no idea what the various types of Charcot-Marie-Tooth were. There were no genetic tests at that time. No genes were known. But we came to the conclusion that more often than not, in most of the families, by the time the person was age 15, if they weren't showing signs of the disease, they probably had escaped it and they would not develop it at a later life. That was actually true for the most common kinds of Charcot-Marie-Tooth, for example, CMT1A, but it wasn't true, as we later learned, for some of the other types. But that was the beginning. That was an attempt to try and do something practical and look at families and help them answer a very simple question. So one of the families that we collected was this family that had been seen in 1962 at Children's Hospital. We entered this family into that study. But in 1980, that family I just showed you had become this family. So this is what had happened to the family over the next 20 or so years. This individual had a couple more children, and then he had grandchildren. And so we now had 3 generations of lots of people in the family, and we could tell by examination and by neuroconductions who had inherited the disease and who had not. And now in 1980, we were doing genetic studies, and the idea was, could we find the gene causing the disease in this family? That was the goal of our study. And in those days, you began by doing what was called a linkage study. You would do blood markers on the blood from individuals in the family, compare affecteds with non-affecteds, and you would try to assign the disease to one of the human chromosomes. No genes had been found at all. In 1980, no one had ever seen a gene for any disease. But we were able to put diseases on chromosomes, at least. This was the picture of one of the boys in that family. You can see remarkable foot drop and lots of atrophy below the knee, and even some atrophy proximally in the thigh muscles. And let's see, can I get this to work? I don't know. Is the audiovisual person? This is a video of one of the young women in that family. Yeah, there we go. And she's just going to show you what you all are always, in fact, already familiar with. Look at her foot drop. So a typical classical Charcot-Marie-Tooth foot drop, and that was what was present in everyone in this family, both the affected boys and the affected girls. And we lucked out. We had very few genetic markers that we could use, but we became very lucky, and we were able to say that in this family, it looked like the gene was on chromosome number 1. And we found that in 1980, and we actually eventually published it in 1982. We actually had 3 or 4 families that we did this same kind of study with. And long story short, it turned out that this was the only family that I just showed you where the gene was on chromosome 1. The other families turned out to have other genes on other chromosomes, but we didn't know that in 1980. And then I started working with a neurologist who decided to specialize in Charcot-Marie-Tooth. His name was Philip Chance, and this is what Phil looked like in 1988. And he was a neurologist and a geneticist, and he decided to study this disease because there were lots of families with it, and also because he had the disease. And we eventually were able to collaborate with some investigators in Japan, and now we're into the early 1990s, And beginning in about 1985, scientists began to find genes underlying diseases. It was very slow at first, but more and more genes were found causing diseases. And in 1993, we discovered that type on chromosome 1 was myelin P0. That's one of the types that Dr. Distad showed you just earlier, the MPZ gene. It was on chromosome 1, and that's what was occurring in our family. So the goal of our initial research to find the gene causing the disease in that family after about 15 years or so was successful. We found that gene. By that time, the more common gene for Charcot-Marie-Tooth had already been discovered by other investigators, and that was called 1A. And so our type was the second to be found, so it got called 1B. And that's where the 1A and the 1B is coming from. And the 1A, as you've heard, is by far the most common. 1B certainly happens, but it is considerably less common. They both are demyelinating forms of Charcot-Marie-Tooth. And then Dr. Chance and the rest of our team here quickly discovered that there was the opposite of CMT1A. CMT1A turns out to be a duplication of a gene. There's an extra copy of it, and you make too much abnormal myelin, and that's why you have Charcot-Marie-Tooth. It turns out that there's a mirror image of that. You have a deletion. Instead of a duplication, you have a deletion of the same gene, and that causes a condition that's called neuropathy with liability to pressure palsies, or hereditary neuropathy with pressure palsy, HNPP. And so Dr. Chance in his lab actually discovered that was what was going on in 1993 here at the UW. And this, you don't hear too much about HNPP, but it's out there, it's quite common. But people don't look like they have Charcot-Marie-Tooth. They get repetitive pressure palsies. They get carpal tunnel syndrome. And when they cross their legs for too long, they get foot drop. And then it can last for months and then go away and then recur again later. And it's passed on from generation to generation. It was historically, and as I said, I like to think historically, it was first described in potato planters and pickers in the Netherlands, and it was called potato picker disease, because they were down on their hands and knees all day long picking potatoes, and they would get up and they would have foot drop, and then it would go away, and it would occur in multiple generations of the family. And so there you go, it's a genetic disease, but it's sort of episodic.
What's the pressure?
Pardon?
What's the pressure?
So when you put pressure on a nerve, usually, for example, if you sit and cross your legs, in fact, probably the best example is toilet seat neuropathy. If you sit on a toilet seat for a long time, you know your toes begin to tingle, and that's because you're putting pressure on your sciatic nerve. And that happens to everyone if you put pressure on long enough. In these individuals, when they would stand up, they would have foot drop. And it would last for weeks sometimes, and then go away. And the same thing would happen if they were using a hammer repetitively. They would get a carpal tunnel syndrome, whereas you might not if you just used it for a small. So those were called pressure palsies. And then in 1996, we made an important observation, which was actually one of the questions earlier, and that is, what can drugs affect this disease in some way? And we discovered that the most important example of that is some of the drugs that are used for chemotherapy for cancer. We had individuals who had cancer and were getting chemotherapy, and they got chemotherapy for a few days, and suddenly they couldn't walk and were in wheelchairs. And some of them were discovered to have Charcot-Marie-Tooth disease, and that it's a risk for chemotherapy. So if you're getting chemotherapy and you have Charcot-Marie-Tooth disease, be sure and tell your oncologists about it, and they need to stay away from certain drugs. the most prominent is vincristine, which has been used prominently in chemotherapy. It's very successful. It's very good. It's a good chemotherapeutic agent, but it's a disaster for people who have Charcot-Marie-Tooth. So, 1998, Greg Carter, who is here today and will talk to you, and who looks about like this today, 20 years later, he's still the same guy. We kept getting questions from patients. They said, you know, we go to our doctors and we have Charcot-Marie-Tooth and we tell them we're having pain, and the doctors say, you can't have pain. We've studied Charcot-Marie-Tooth, we've read about it in the textbooks, and the textbooks say it's a painless neuropathy. So you can't have pain. Go away. Isn't that right, Greg? That's what they would say, but I'm having pain. I am. And so we did this simple questionnaire survey of hundreds of people with Charcot-Marie-Tooth across the country and asked them, do you have pain or not? And if you do, where and what kind of pain, and so on and so forth. And the answers came back, absolutely. Pain is quite common in Charcot-Marie-Tooth, and there are really at least two different kinds. There's musculoskeletal pain, which is because your muscles and joints aren't working properly. And the other is what's called neuropathic pain. Because the nerves are degenerating, they cause pain. And so if you have Charcot-Marie-Tooth and you have pain, we believe you. It does happen. And then in 2000, we were continuing to pursue the genetic story. And this is this is Dr. Phil Chance again, and we teamed up with a PhD molecular biologist at the University of Washington named Val Street. And Val Street also has Charcot-Marie-Tooth. So Dr. Chance and Dr. Street both had Charcot-Marie-Tooth, and we were studying additional families. 1A and 1B had been found, X had been found, but it was still not all the families had those genes, so there must have been more genes causing this disease. And sure enough, in 2003, we found another one called 1C. So now we'd gone from 1A to 1B to 1C, and it makes sense that the most common one was found first, and 1B is less common than 1A, and 1C is less common than the other two. But it happens, and it's been adding to the alphabet soup of Charcot-Marie-Tooth. In 2005, over a period of 4 or 5 years, the group here at the University of Washington found a gene that causes another unusual hereditary nerve disease. It's called hereditary brachial neuropathy. It's quite unusual. People are doing fine. They don't have foot drop. They don't have atrophy of their hands. And all of a sudden, they will get a severe, painful nerve problem with their arm, usually the upper arm and the brachial plexus. And so it got called hereditary brachial neuropathy. But it's painful. It comes on suddenly, and they get weakness and can sometimes develop atrophy. And then over a period of weeks to months, it slowly goes away. And then a year or two later, it recurs. And sometimes it can recur in the same arm or sometimes in the other arm. Occasionally, it can occur in the leg. So it's a sudden onset, very painful, focal nerve disease. And in addition to that, it's inherited. So a parent can have it, and their children have a 50-50 chance of also inheriting it. So it's called hereditary brachial neuropathy. It's also been called hereditary neuralgic amyotrophy. So neuralgic means it's painful, and amyotrophy means it causes weakness. And it usually affects the upper arm, but it actually can affect any nerves. And it's genetic, and our group discovered that it was various kinds of mutations in a gene called the CEPT9 gene. Michael Weiss, who was going to be here today but was unable to make it, is a neurologist that's in the Charcot-Marie-Tooth Center at the UW, and he and other people in the team were actually studying genetic neuropathy in a mouse model. So there are mice that can get various kinds of Charcot-Marie-Tooth, and one of them is called the Trembler J mouse. And Dr. Weiss and others have been investigating what happens in the nerves in mice with these various types of Charcot-Marie-Tooth. And then this was actually one of the earliest families I saw with Charcot-Marie-Tooth when I first started here at the University of Washington. This individual with an arrow was a woman who presented with classic Charcot-Marie-Tooth. And I first saw her in the early 70s. And so it's been more than 40 years that I've been following this family off and on. They actually are spread all over the country. And when I first saw them, I just saw this little piece of the family, about that much. And now 40 some years later, this is what has come of the family. And there's something really remarkable about this family tree when a geneticist looks at it. Usually you just look at it and say, well, that's Charcot-Marie-Tooth. It's multiple generations. Boys and girls are both affected. But a key observation of this family pedigree is that no male has ever passed it on to a son. So you look at this, and you can see here's a male, he has a son, the son is fine. Here's a male, he had a daughter and two sons. The daughter had the disease, but neither of his sons got it, and so forth. You can't find a male in here that's passed it on to his son. And to geneticists, that means bingo, that's X-linked disease. Dr. Distad was just telling you about that. So this family has X-linked Charcot-Marie-Tooth disease. And it is dominant because the women have symptoms. The men are quite severely affected. The women are all over the place. There are some that are so mild they don't even realize they've got it, but they have mild findings when you examine them. And there are other women that have foot drop and are wearing braces and have actually had foot surgery. So the women vary a great deal. The men are much more affected. And in the 1990s, the early 1990s, the gene causing X-linked Charcot-Marie-Tooth disease was discovered. And we tested this family for that gene, and they were normal. They didn't have a mutation in it. So this family sat around for years, more than 25 years, with us not knowing what was going on. And then a group in London reported two very small families with an X-linked form of Charcot-Marie-Tooth, and they discovered that in fact they had a mutation in the gene that causes classic X-linked Charcot-Marie-Tooth, but it was way out in the edges of the gene where the testing didn't look. And so we went back and tested our family for that region, and sure enough, that's what they had. They had the same mutation as the family in London. And the test was missing it because they didn't go far enough out into the gene when they looked genetically. So this family that I've been following for more than 40 years, we finally were able to show what the gene was in that family. And that was, we just reported this family in Muscle and Nerve this year, 2018. So that's my 40-year odyssey of Charcot-Marie-Tooth here at the University of Washington. We haven't stopped. This is the group I'm working with now in the lab of Wendy Raskin and Dongwei Chen. And our medical genetics fellow, Dr. Inbui, is actually at a genetics meeting in San Diego right now, presenting our latest genetic work on Charcot-Marie-Tooth. We're focusing on late onset families with axonal disease. So families where the disease doesn't appear until after age 40, and it's familial, you find it in multiple members of the family, we're looking for the genes that are involved in that kind of phenomenon. That's very different from usual Charcot-Marie-Tooth, which often comes on in childhood or adolescence, certainly before age 40. But there are families where it's late onset and it's axonal and it's familial. And we're beginning to find a few mutations in genes that can do that. So 40 years, we haven't given up. We're still looking. If you happen to have a family that I've just described, let me know, because we're looking for such families. And thank you very much for your attention.